With the permission of Honorable Chairperson, I would like to request our first speaker for this session, Professor Abdullah Al-Shafi Majumder, to give his presentation in the topic of Update of Heart Failure with Preserved Ejection Fraction. Professor Majumder, sir, is the ex-director and professor of Cardiology, National Institute of Cardiovascular Disease. He is also Secretary General of Bangladesh Cardiac Society. Professor Abdullah Shafi Majumder, sir. Sir, can you share the...
Yeah.
Sir, unmute, please.
Yeah, I unmuted, yeah. Thank you, the dear moderators and the respected chairpersons. It is very unjust to me to give some only the 10 minutes to give the updates on the heart failure with preserved ejection fraction. I don't know. I wonder whether I can do justice of the topic. Anyway, my thanks to Professor Abdul Qadir Akand and Professor Amir Jaman, Dr. Firoz, the team that organized this program. Sorry. It does not work. And this is the heart failure with preserved ejection fraction is the path is very foggy and misty because there are many information yet to be settled. So I will make the presentation in this formats: the introduction, pathophysiology, diagnosis, treatment strategy, COVID-19 and heart failure with preserved ejection fraction, and take-home message. Mind it that at least 50%, and some authors say that more than 50% of the heart failure are due to the heart failure with preserved ejection fraction, affecting roughly 5% of the general population aged more than 60 years. And it is an increase, it is very alarming that it's increasing at the rate of 1% per year, with the overwhelming majority of the patients being more than 65 years. Is risk factors, obesity, hypertension, and diabetes, all of which are increasing in prevalence, and thus the expected rising prevalence of the heart failure with preserved ejection fraction. Say a case, the female of 65 years with the shortness of breath for the last few months with the NIH class 2 to 3, no history of cough or asthma, she is hypertensive, diabetic, ECG shows some subtle changes in the STT, X-ray is normal, the normal renal function lipid profile, echocardiography shows concentric hypertrophy with LVF around 55%. The diastolic dysfunction is recorded as altered EA by A ratio. Body weight is around 90 kg with height 166 centimeter. Further echo assessment shows the PSP 54 millimeter of mercury, and the E by E prime ratio is more than 16. LA dimension is around 33-34 ml per square meter. Previous ECG shows the atrial fibrillation. BNP level is 30 picogram per ml. Before going to have the diagnosis, let us have the pathophysiology. Cardiovascular and non-cardiovascular coexisting morbidities lead to a systemic inflammatory state, perturbing the physiology of the endothelium and the perivascular environment, and engaging molecular pathways that ultimately converge to myocardial fibrosis. And this is the, in nutshell, this is the pathophysiology of the heart failure with the preserved ejection fraction. So there is a diagram. It is increasingly recognized as the systemic disease rather than an isolated cardiac disease. That is the hypertension, diabetes, kidney disease, obesity, all these factors lead to the some changes in the myocardium, left ventricular hypertrophy, and the left ventricular volume increase. There is endothelial dysfunction. There is a impaired myocardial relaxation. There is interstitial fibrosis. And the extramyocardial origin in the progression of the preserved ejection fraction heart failure is in contradistinction with the heart failure with reduced ejection fraction. That is, though they both are heart failure, but pathophysiologically they are quite different entity. This is the same things and by the different authors, how the systemic inflammation leads to the number of the pathophysiological cellular changes. I think that this topic will be discussed with one of the speakers in this session. There is a microvascular inflammation, endothelial dysfunction, and ultimately the heart failure with preserved ejection fraction. This is the phenotypic pathophysiological phenotyping of the heart failure with preserved ejection fraction, obesity, pulmonary vascular disease, and RV dysfunction, myocardial ischemia. All these are the points that are associated with the phenotypic association with the heart failure with preserved ejection fraction. Phenotyping based upon of the pathophysiology, comorbidities, or some combination may provide targeted therapies. So why we are concerned with the pathophysiology? Because the targeted therapies can be made to the specific heart failure with preserved ejection fraction subpopulation that are positioned to derive the greatest benefit. So echocardiography plays the key role in the diagnosis, and conditions mimicking the heart failure with preserved ejection fraction are identified. For example, the amyloid heart disease, initially it was included in this group, though preserved ejection fraction, but there is some impairment of the left systolic performance. Pulmonary hypertension is seen in roughly 80%. RV systolic dysfunction may be present, and LA remodeling and dysfunction leading to the LA cardiomyopathy. These are the echocardiographic features. Diastolic dysfunction versus the heart failure with preserved ejection fraction. It is very misnomer to tell is this the diastolic heart failure, because the diastolic dysfunction is a pathophysiological condition and can present in the absence of the heart failure, whereas heart failure with preserved ejection fraction is a clinical syndrome that may be present without diastolic dysfunction. So diastolic dysfunction, though it is the central to the heart failure with preserved ejection fraction, but not all patients with the diastolic dysfunction have or will develop clinical heart failure with preserved ejection fraction. So we should be careful to coin the terminology diastolic heart failure in place of the heart failure with preserved ejection fraction. And there are the presence of the systolic dysfunction is there in the heart failure with preserved ejection fraction, as we can measure by the global longitudinal strain on the strain, or tissue Doppler mitral annular systolic velocity, or mitral annular plane systolic excursion. All these are abnormal in a group of people with the heart failure with preserved ejection fraction. Mind it, the presence of systolic dysfunction predicts the worst prognosis. So you know how to measure the filling pressure of the left ventricular filling pressure. It is very easy for the cardiologist to understand this chart. If the EA ratio is 0.8 and the E is less than 50, that means the normal left atrial pressure. When the EA ratio is more than 2, it means the more than LA pressure is increased. In between, we have to make the E by E prime ratio measurement. We have to make the peak tricuspid agitation velocity, and we have to measure the left atrial volume index. If the 2 is positive, then it is left atrial pressure is increased. If 2 is negative, it is the normal left atrial pressure. So 3 components in the diagnosis of the heart failure. The symptoms and signs of the heart failure must be present. The preserved ejection fraction, that is the left ventricular ejection fraction, 50 or more, and diastolic dysfunction. Pathologic LV hypertrophy by itself is recognized as an indicator of the myocardial disease and diastolic dysfunction. So in the recently, the last year, there is a scoring system, HFpEF scoring system. This is from the American side. The H2 means 2H, heavy obesity, more than 30 kg, 2, hypertension, and the 1, active fibrillation, paroxysmal or persistent is 3, pulmonary hypertension 1, elderly more than 60 years is 1, ILV filling pressure, E by E prime more than 9 is 1, so total 0 to 9. If the scoring is more than 6, it is highly likely the patients are heart failure with preserved ejection fraction. And there is another, and in our patient, she is obese, she is hypertensive, all this calculating his points, the 6 points, so diagnosis of heart failure with preserved ejection fraction is highly likely. And this is the European guidelines, the last European Heart Failure Association of the European Society of Cardiology make a scoring system, the step P, they call the step P, step P means clinical signs and symptoms, clinical assessment. Then the ECG, X-ray, and echocardiography, usual ECG, X-ray, echocardiography, if possible, also the natriuretic peptides. And these results will suggestive, if the suggestive of the heart failure with preserved ejection fraction, then go to the heart failure association PAF scoring system. PAF scoring system, if it is high, then it is confirmed heart failure with preserved ejection fraction. If it is low, then the other other conditions should be thought of. And if it is intermediate, then we have to have some diastolic stress test or invasive hemodynamics. And this is the scoring point. There is the functional, morphological biomarkers, and they have got the major points. Each major point has got the 2, and one minor point is 1. So total is the if the 5 or more, then the patient is heart failure with preserved ejection fraction. If it is the 1, then it is not the heart failure with preserved ejection fraction. 2 to 4, and we have to do the diastolic stress test and invasive hemodynamic measurements. So what is the advanced assessment of the heart failure with preserved ejection fractions? These are the same things in the tabulated form. So the one paper has been published this June. The heart failure association PAF score is not only as a diagnostic tool, but also a practical prognostic tool. These are the risk factors of the heart failure of the preserved ejection fraction: the advanced age, overweight, metabolic syndrome, or diabetes mellitus, physical inactivity, arterial hypertension, atrial fibrillation. These are all the risk factors of the preserved ejection fraction, and these are the conditions that may mimic the heart failure of the preserved ejection fraction. The valvular heart disease, coronary artery disease, pulmonary hypertension, high output failure, pulmonary hypertrophic cardiomyopathy, all these cardiomyopathies, all these are mimicking the. What is the condition of the natriuretic peptides? BNP levels are elevated in the presence of the heart failure, whether it is reduced or preserved, but it is lower in the preserved ejection fraction than the reduced ejection fraction. More predictive value in the heart failure with reduced ejection fraction. There is a challenges in the management because the heterogeneous, actually it is a syndrome. The heart failure with preserved ejection fraction is not a single entity, it is heterogeneous. Multifactorial pathophysiology, different phenotypes, empirical treatment, management of comorbidities is required. And last of all, myocardial fibrosis and excessive extracellular matrix is the major determinants of the features of the heart failure with preserved ejection fraction. These are the challenges. So to date, unlike the heart failure with reduced ejection fraction, which have a lot of drugs, lot of management plan, but the heart failure with preserved ejection fraction is still orphan of treatments. This comment is made in an article just published April this year. So we have to make the risk factor management. We have the management of the heart failure. If it is tachycardia, anti-tachycardia treatment, but mind it, in 1/3 of the patient, there may be chronotropic incompetence. So beta blockers should be avoided in those patients. Treating the atrial fibrillation, treating hypervolemia by diuretics or salt restriction, and weight management by the physical exercise. And what is the drugs therapy? Most of the drugs are found to be not so much effective in the case of the heart failure with preserved ejection fraction in comparison with the heart failure with reduced ejection fraction. So it comes the PARAMOUNT heart failure trial where the ARNI versus valsartan was used, whether in the heart failure with preserved ejection fraction, and showed that it reduced the NT-proBNP level, decreased the LS size, and improved NOH class. So ARNI was found to be a beneficial effect. But in the PARAGON HF trial, which has been published in the 2019 ESC meeting, there is a statistical significance of the primary endpoint was just missed because P is 0.059. That is heterogeneity of the treatment effect with the suggestion of benefit in patients with the ejection fraction in the lower part, 45 to 57 of the range studied, and in women. These are the two groups, 45 to 57 group, ejection fraction, and the women. They got the beneficial effect, the PARAGON HF. Then the PARALLAX trial was published in the last year in the ESC, And they also showed that there is a reduction in the NT-proBNP, but there is no difference between the improvement of the 6-minute walk distance and quality of life improved in both groups, but there is no difference between the groups. So the comments was there that the heart failure with preserved ejection fraction continues to be a real challenge in terms of the effective therapy, that this type of the heart muscle disease has so many potential underlying mechanisms, ischemia, fibrosis, hypertrophy. So we need the better phenotyping and better therapeutic agents for the particular phenotype group. And this is one of the meta-analysis which found that in the case of the ARNI also beneficial in the case of the heart failure with preserved ejection fraction. The thing is that as we know, the preserved ejection fraction has been termed 50 or plus, some say 45 plus. So this analysis show that the LVF of 40 to 55, several heart failure treatments might provide benefit. So left ventricular ejection fraction in the preserved ejection fraction patient it matters. And Tresto at last, on the last February, is USA FDA approved the use of ARNI to use in the certain groups of the heart failure of ejection fraction. Until then, no therapies have been approved for the heart failure with preserved ejection fraction. Another trial was just published 2 months or 3 months back, that the treatment with the pirfenidone, which is antifibrotic used by the pulmonologist, for 52 weeks reduced the myocardial fibrosis compared to placebo in patients with heart failure with preserved ejection fraction and the evidence of the myocardial fibrosis. The future direction are typically associated with the aging, diabetes mellitus, hypertension, etc., etc. So multiple phenotypes, and future clinical trials may need to stratify the heart failure with preserved ejection fraction into clinical groups, aging groups, EF group, genetic groups, and so on. And by this, we can choose the appropriate drug for the appropriate phenotype of the heart failure with preserved ejection fraction. These are the recommendations from the ESC 2016 and SSC 2017. You have already seen it. And now the new anti-diabetic agents which throw light on the heart failure with preserved ejection fraction. The SGLT2 inhibitors is poised to ameliorate many of the pathophysiological abnormalities seen in the heart failure with preserved ejection fraction, and authors found a light in the end of the tunnel. And just a news here, the phase 3 trial with the SGLT2 inhibitors meets the primary endpoint in heart failure with preserved ejection fraction. Emperor met its primary endpoint and showed a significant risk reduction with empagliflozin for the composite of CV death or heart failure hospitalization compared to the placebo in adults with the heart failure preserved ejection fraction with or without diabetes. So another point is the COVID-19 may be a precursor of the heart failure. The preserved ejection fraction, these are pathological link up between these two. So the COVID-19 survivors may present a novel independent risk factor for the development of the heart failure with the preserved ejection fraction. So, ladies and gentlemen, the respected chairpersons, the moderators, at the end, the heart failure with preserved ejection fraction is a heterogeneous clinical syndrome with complex etiology and pathophysiology. Echocardiography plays a pivotal role along with the clinical features and biomarkers. HFpEF, developed by the Americans, and HFpEF, they developed by the Europeans. These are the two scoring system methods that make the diagnosis to be uniform. And results of the therapeutic trials with an agent of the heart failure with preserved ejection fraction as a group have been disappointing. Addressing the risk factors is the important step to manage the heart failure with preserved ejection fraction. Till now, ARNI is the only approved drug in a selected heart failure with the preserved ejection fraction patient. Empagliflozin is reported to meet the primary endpoint in the forthcoming trial, EMPA-PRESERVE trial, and there is no single approach of management is recommended to be phenotype-based. Future clinical trials need to be undertaken with considering the phenotypes and genotypes of the diseases, rather including the patients without discrimination. And that's all. Thank you very much for the patient hearing.